All right, everyone, welcome back to another episode of Forward Physio. Today, I'm very fortunate to be with Scott Greenberg. And I had heard Scott on one or two podcasts in the past. And what really started to kick this podcast into gear was I was looking for somebody to create a case study for Physio Network on Achilles ruptures. And Dr. Karin Silbernagel recommended Scott. And if that name doesn't ring a bell to you, just know that's very high praise in the Achilles world.
I need to send her a Christmas card, huh? Is that what you're telling me? Yep.
Yeah,
Okay.
I guess so. And I'll send her one too because hey, you created a really, really good case study for us. So I've been learning from Scott over the past few months or so on Achilles ruptures, and I just wanted to have an extended conversation with him today. But before we get into all things Achilles ruptures, Scott, can you give just a little bit of an introduction into who you are and what you do professionally?
Sure. So again, thanks for having me. This is awesome. I love talking Achilles. So I've been a PT for going on about 25 years now. Outpatient orthopedic sports medicine is my thing. I live and work in Gainesville, Florida, and have been here the entire time of my professional career. I'm fortunate right now to work for UF Health, in which I am the manager of operations for the outpatient rehab department. I'm the residency director of our sports residency program, and I'm fortunate enough to still continue to treat our Gator athletes. That's the only treatment I do these days. So I treat probably about 20 hours a week, give or take, 15, 20 hours a week. And my area of expertise, and I'm putting air quotes into expertise, right? So the area I spend a lot of time treating is lower extremity, specifically foot and ankle. I do a lot with running mechanics. I've done a lot with foot orthoses. I'm pretty active in the American Academy of Sports Physical Therapy, where I'm the membership chair currently, and I have been the running SIG chair in the past as well. So that's kind of me in a nutshell. I love talking all things tendon, especially in the foot and ankle, and Achilles tendons are one of my favorite things to really treat. So I'm excited to talk.
Yeah, me too. You don't sound busy at all, Scott. Doesn't sound like there's a lot going on there.
That's right. Yeah, my wife wonders why I come home and I just lay on the couch. It's because I'm excited. I'm extremely exhausted from my day's activities. So it's good.
No kidding. What were you doing before University of Florida?
So I've been with the UF since 2002. Prior to that, I worked for 2 years at a private practice. Fortunate enough, honestly, it's early in your career. You want to surround yourself with really bright people, and I was fortunate enough to really surround myself with an amazing group of individuals. One of my biggest mentors was a guy by the name of Marty Hugel. He's one of the godfathers of sports physical therapy, was the Gator physical therapist for years and years and years. He worked very closely with Pete Indelicato, who's a long-term orthopedic surgeon. Keith Meister were the two Gator docs during that time, and that's really why I made my move over to UF Health, is because that's where those docs were located, and I wanted to associate myself with them and be part of their practice, and then that led to other things, all things being able to treat the Gator athletes and such. So. It's surround yourself with good people, good mentors, and hopefully never say no and do a good job, and hopefully good things happen.
Cool. Okay, lesson learned.
Yeah.
All right, let's do it. Let's talk all things Achilles ruptures. So, why do these ruptures happen in the first place, and what is the mechanism of injury, and does that mechanism ever differ?
Yeah, I'd say there's a lot of different reasons. Oftentimes we find that the Achilles tendon itself is not always in a healthy state when these things occur, right? In a study of looking at, I think it was gymnasts, when they looked at the ruptured side and then did a contralateral comparison on ultrasound, a vast majority of them were not necessarily healthy pieces of tissue either. So oftentimes leading up to an Achilles rupture, not always, but oftentimes there's a period of time in which they're complaining of pain and soreness in that region, whether the tendon has become slightly degenerative or such. But usually it's a mechanism of either a forced dorsiflexion kind of mechanism, or even a forced plantar flexion motion for that matter, in the form of jumping, hopping. In the case of a lot of people, it's not sexy. They take a step back and their Achilles pops oftentimes. It's kind of like, it was like the straw that broke the camel's back. But the mechanism does vary, I think, from sport to sport a little bit, from activity to activity. you do see it with forced dorsiflexion and a lot of aggressive plantar flexion too.
Yeah, it's such an interesting injury sometimes, because you're right. Sometimes it just seems like such like an innocuous, simple movement that you would
Mm-hmm.
think the athlete would handle with no problem, and they
Mm-hmm.
just step back and try and accelerate, and it just pops.
Yeah, they say sometimes it's like a deceleration to an acceleration kind of moment. Sometimes also that could create it. So across the spectrum, there's a wide reason as to why these things happen, and it's just bad position, wrong position at the wrong time, right? Getting that tendon in a weakened state and just putting a certain amount of force through it, and it kind of can go.
Yeah. So let's say it does go,
Mm-hmm.
unfortunately, right? A lot
Mm-hmm.
of people, I know my little brother actually ruptured his Achilles in May. And just from the patients that I've had that have also ruptured theirs, I think the first place they go to is the internet. And they try and just, like figure out
Dr.
what did they
Google.
do
Dr.
exactly.
Google. Uh-huh.
Yeah. Yeah, you can't beat Google. Or I guess these
Right.
days ChatGPT.
That's right.
So what does someone do when they rupture their Achilles? What are their options?
Great question. So I think a lot will depend on, the age of the person and what their goals are and their activity level. So, in the sports population, we tend to see surgical management the vast majority of the cases. And there's reasons for that we can get into. But we're starting to see now that in older adults, the weekend warrior, where this does sometimes happen, as well. A lot of pickleball and tennis players are now starting to have this type of injury as well. And non-surgical management is also appropriate in a lot of these cases. The key with a non-surgical approach to the management of an Achilles rupture is early intervention. And by that, I mean you got to catch it within the first day or so. And then you've got to lock that person up into a plantar flex position for a prolonged period of time. And just allow those two pieces of tissue to approximate and heal, scar in, and the outcomes are actually fairly good at about a year, 12 months out in terms of strength and return. They're actually pretty close to those that are treated operatively. The benefits of going non-operatively are obvious, right? No surgery, so lower infection rate, right? No infection rate, lower
Right.
infection rate. That's not to say there aren't complications. There can be complications, sure, but in terms of infection, there's no open wounds, so that's not an issue. The cost of the procedure is obviously a lot less. It's typical rehab, which you're going to have after surgical intervention as well. The rehab is a little bit slower. You tend to be a little bit more conservative with these because, again, you want to make sure that you have ample time to scar in and heal up. You want to make sure that the blood supply to the area of the posterior heel is not great. In the area where these tend to rupture, about 4 to 6 centimeters proximal to the calcaneus insertion. So that's not great. You got to pick your patients well. So anybody with poor circulatory issues, obviously maybe not the person to kind of go down this route. There is a slightly higher re-rupture rate with the non-operative approach, but in a lot of studies, it's not significant.
Yeah.
So you just got to, again, pick your patients well. The reason why athletes and younger people tend to go with the surgical route is you can be a little bit more aggressive early on. So return to sport and functions a lot quicker. And you've got that secondary restraint to guide them and to help them when they do get back and to do, again, progress the rehab a lot quicker. So that peace of mind and that structural stability via the sutures and the anchor into the heel are in some cases with like the speed bridge, the anchor into the heel, can be beneficial in allowing you to do a lot more, a lot quicker.
What is that re-rupture rate, if you could recall, or what is it around?
It varies. I think depending on the study, I think in the non-operative, it was around 12%, and maybe like 3 to 6%, 4 to 6% in the operative group. Again, depending on the study that you read, and a lot's going to depend on, you pick your patients, right? So if you do surgery on an athlete or a person that's not going to be stressing it, their likelihood of re-rupture is lower versus somebody getting back to high stressful, high performance type of environments, their risk is going to be a little bit greater.
Right. Like we can look at these averages, but we always have to, consider the individual in front of us.
Yeah.
I think it's just worth noting that, just the fact that conservative management is an option, I think debunks potentially a myth that people believe that these ligaments, these big ligaments, can't heal sometimes, but
Mm-hmm.
they absolutely can with proper conservative management, right?
Mm-hmm. Well, again, you're talking, ligaments versus tendons, and
Oh,
can they
sorry,
both
yeah,
heal? Yeah, can they both heal equally?
yeah,
And I think the answer is, I think they can, if you can get those two ends together close enough, right? So that's why you got to get after it really quick, so that that tissue doesn't have super long time to like recoil and to kind of get itself caught underneath the musculature of the lower leg. So
mm,
got to catch them early, got to get them into that plantar flex position. You got to lock them up for a good 6 weeks or so, and just make sure that that tissue is nice and approximated.
right. Okay, so let's talk about that early management then, and how it may differ in terms of surgical and non-surgical treatment. You're saying that one of the first steps is to lock them up into that plantar flex position. How is that typically done? Is it a cast? Is it a boot?
I typically see post-op splints more so than casting, and the reason being is if there is any swelling, a cast is non-forgiving, whereas a
Mm,
splint gives you a little bit more room to kind of expand, while still locking them up and not allowing them to move into any dorsiflex position. So I tend to see the post-op splint for about 2 weeks, and then following that, usually get placed into a boot, non-weight bearing, with two heel lifts to
hmm
really keep them, again, plantar flexed. Some doctors will keep them, most doctors will keep them non-weight bearing for a good 4 weeks, maybe even 5 or 6 weeks, depending on, again, the age of the patient, how good the repair was. Because when that tissue tears, sometimes it explodes, right? And you got a crappy piece of tissue on the proximal end, you got a crappy piece of tissue on the distal end, and you're taking two crappy pieces of tissue and trying to tie them together. And
Right.
depending on what that looks like and how good of a repair they have, that may kind of create a more conservative approach to some of the management. That being said, there are some studies out there now that really kind of debunk this whole non-weight bearing early, and really promote more of an early weight bearing type of situation. And what that does is, I think it increases blood flow, which is good, which heals, which can bring nutrition and healing properties to that area, and also just, I think, just allows that tendon to feel a little bit of stress in a controlled manner, so that the tissue itself can start to rebuild itself, as
hmm
opposed to just kind of just laying dormant for 6 weeks doing nothing. So there's a balance there, and you don't want to create a whole lot of tension and force through that tendon, but a little bit of tension, we'll say, may be healthy.
Right. And not necessarily in the form of, like lengthening the tendon into dorsiflexion early on, but more
Correct.
so like just putting some load through it when you're
Correct.
weight bearing.
Correct.
I read a randomized controlled trial recently. I think Dr. Karin may have been one of the authors on it, but I could be wrong.
Mm-hmm.
And it was looking at early weight bearing,
Mm-hmm.
and they're sort of looking at the re-rupture rates as the primary outcome.
Mm-hmm.
And basically, the authors are sort of hypothesizing that with early weight bearing, with conservative management, that re-rupture rate may get a little bit lower. What are your thoughts on that?
So there was a study, I'm looking at it actually right now. I think I just pulled it up I think it was in, what year was this? 2013. They looked at a re-rupture rate after early weight bearing in operative and non-operative situations, and they found no difference in re-rupture rates between the surgically and non-surgically treated patients with early weight bearing, and early weight bearing was at 4 weeks.
Mm-hmm.
So it didn't really have an effect on the re-rupture rate, whether you were treated operatively or non-operatively. Now, again, this is one study back in 2013. They looked at 500. It looks like 576 patients they looked at. So a pretty large group. So that's just one example of really a push to allow people to start weight bearing in a, again, controlled manner earlier on than we would typically expect. So we
Right.
typically do start our weight bearing around 4 or 5 weeks in that really protected state, with the ankle plantar flexed, with two heel lifts, with crutches, and then we start to take away one heel lift. Then we take them out of the boot and we put them into a shoe with two heel lifts and one heel lift. So it's a progressive thing over the course of probably 5 to 8 weeks, in which we're starting to weight bear, get them out of the boot, decrease the height of the lift, etc. But again, you and I talked offline and talked a little bit in the case, not all boots are created equal, and the boots we typically use are a shelled kind of wedge system. There are some boots out there that have a more of a strut, and they don't do nearly as good of a job of unloading the tendon as those wedged boots do. So just keep that in mind. And that was at 30 degrees of a wedge, 15 degrees of a wedge, as well as different walking speeds. So those strutted boots are not the best for this particular diagnosis.
Right. And in that study that looked at those different boots, I know like the difference was more prevalent at these early points of rehab when the ankle is more plantar flexed. So when
Correct.
you're at like 30 or 20 degrees, but as you came into that flat part, there wasn't as much of a difference between the boots, but maybe by that point, it doesn't matter as much compared to the earlier weeks when you're trying to.
When it does matter.
Right.
Correct.
Right.
Correct.
What I'm curious about is that now there's this sort of push for early weight bearing or earlier weight bearing. Now, is it possible that we do want a little bit more load through that tendon with one of these strut boots, like the Vacoped boot, or does it depend on the individual? I'm curious on your thoughts there.
My thought on that, I would like to be the one that controls the load put through the tendon. I don't want to rely on a boot to put load through the tendon all throughout the day either, right? Every step that they take, 5, 6, 7, 8, 9, 10 hours on their feet all day. That's a lot. That can be a lot, right? Versus somebody comes in, you give them a little bit of a load, let's say during a therapeutic intervention. It's very, very structured. It's very controlled. You know what they're doing when they're with you. You know what they're doing when they're not with you, as opposed to kind of just going willy-nilly at it and allowing the tendon to take all this kind of load for prolonged periods of time. So
right.
I would be very cautious with that. Again, I like to control when I'm putting the load through. And again, I think just like anything else, there is a breaking point. A little bit of load may be good, but just like anything, too much of a good thing can be a bad thing. So I think we just need to keep that in mind.
And definitely easy to have too much of a bad thing when the patient's off on their own with this really, really, this injury that's unlike most, where I don't think it's very often where you rupture something or when you damage tissue that isn't bone, and then you're put into this protective thing and told that you shouldn't be weight bearing for a little bit. Obviously there's other instances, but for most people, I think when they rupture their Achilles, it's usually unlike any injury that they've had before.
One of the reasons I really like it is most of the time these injuries are non-painful really when they happen.
Yeah.
And the rehab in most cases is pretty non-painful as well. You get some soreness and some stiffness occasionally, but it's not like a lot of other injuries like rotator cuff tears and repairs and labral repair. Like shoulder stuff just stinks. It's just debilitating. People can't move. It hurts. ACLs at times can be pretty painful early on when you're trying to bend your knee. Trying to get full extension can sometimes be real. These do pretty well, honestly, from a pain standpoint, especially when you manage them the way we manage them early on, which is protecting it, and really not pushing that motion, which is another whole topic we can get into.
Yeah, I think that's coming up. But before we talk about that increase in motion, when it comes to the point in which you start to have protected weight bearing with the crutches and with the boot, you said 4 to 5 weeks. Is that 4 to 5 weeks after the rupture in the case of conservative management and 4 to 5 weeks after the repair?
I would probably be after the repair. Most of the time is where we'd start that at that time frame. With the non-surgical management, I think again you've got to be a little bit more cautious. It's going to be a longer rehab process. I always say, in most cases, a little extra protection for a week or two will go a long way in terms of your long-term outcome. So, if we have a non-athletic person, let's say somebody who's not looking to get back to a career that pays them money, being a little bit more conservative for an extra 2 weeks, I think will pay dividends. And it's risk versus reward, right? How much risk versus how much reward? And in all of medicine, we were always juggling that, right? So any injury, you've got to look at a whole bunch of factors, right? is it their senior season and they're never going to play this sport again? And are they going to really run the risk of really doing more damage, or are they just kind of going to have a sore whatever throughout the course of their training? Could it have long-term effects? Can it really debilitate their ability to earn a living if they push this too far? All of that needs to be judged in the equation when you're making these decisions. And it's not just a therapy decision. It's not just a doctor decision. It's the entire continuum of the patient, the patient's family, and somebody in a lot of these cases, the physician, the coach, all of that kind of plays into it when you make these medical decisions. And ultimately the patient, if they're older than 18, right? Ultimately the patient really kind of decides what and how they want to do it with the guidance of the physician and the orthopedic surgeons and the therapists and the whole team.
Right. So I think just to summarize this whole notion of surgical versus non-surgical, it sounds like in the long term outcomes are a little bit similar, but if you're maybe working with a high performing athlete who needs to get back to their sport a little bit quicker than, the 30 or 40-year-old who's just playing pickleball, then maybe surgical may be a better option for them because you could sort of accelerate the recovery or the rehab rather a little bit.
Because you've got that secondary restraint. You've got something that's pulling those tissues together, right? And then you can be a little bit more aggressive with your loading program, which ultimately, in my opinion, is the main reason why somebody is slow or fast to get back to sport. At about 6 months, that tissue is in its maturing state. It starts to plateau around that 6-month mark. But if you look at return to sport timeframes, it's usually 10, 11, 12 months, depending on the population that you're dealing with, to get back. Why is that? Well, oftentimes they don't have the strength needed to do the demands of the sport. It's not that the tissue, now again, the tissue is still healing some, but at that 6-month mark, they're in a pretty good spot from a tissue standpoint. So if we can get them to be stronger earlier, like I always, talk about Rob Panarella's model and Al Vermeil's model about, building a good platform. You've got this good foundation of movement, and on top of that foundation of movement, then you got strength, then you get more of explosive strength, then you get more of reactive strength, and then you get speed. Well, you can't have speed without reactive strength. You can't have reactive strength without explosiveness, which you can't have without having a strong foundation of strength, which again, you're not going to be very strong through a large range of motion if you don't move very well. So that's kind of how it all kind of plays. And you've got to build the foundation. And if you start skipping steps and not really building that foundation, your reactive strength is going to suffer, your speed is going to suffer. And that's what, that's why some of these, professional athletes' careers are shortened, because they never have that good strength base to get back and return. And we see it in ACLs, right? That first year back is always, most of the time, like a subpar year for them. It's usually year 2, year 3, unless you're like Adrian Peterson and a freak, right? But in most of the cases, it's year 2 or 3 where they really start to feel comfortable. Their strength is back and they're ready to roll. That first year back is they're kind of feeling it out a little bit, gaining confidence in it. They're lacking some of the strength that the other side has. So I think this is no different. The problem and the limitation with the Achilles is you can't start strengthening day one like you can with an Achilles, with an ACL reconstruction, and start strengthening that quad, right? You start quad strengthening day one. With an Achilles, you don't start day one, right? You start probably moving it around, maybe doing some active range of motion at a week, maybe week 4 for plantar flexion. And then you can start doing some progressive resistance stuff, maybe week 6-ish. Again, the protocols of surgeon to surgeon is going to vary a little bit, but say week 6-ish. We have cool tools now that allow us to accelerate that a little earlier. I'm a big, blood flow restriction guy. I start blood flow restriction day 1 post-op on the other side because there is a systemic effect to it. So I do, for the first 2 weeks, I'm doing BFR on the other side. At about the 2-week mark, I might start doing, again, depending on the wound, because again, wound closure is the most important thing early on. If you don't get that wound to close, infection goes high. You turn into a mess of problems if that skin, which is really, really thin on the back, doesn't approximate and doesn't close up. So, making sure that the swelling is minimal, making sure that the wound is closed. Then I will start blood flow restriction on the surgical side, and I'll start big muscle groups first. I'll do quad stuff. I'll do hamstring stuff. I'll do glute stuff, right? Mainly quad and hamstring stuff, though. I think you get the most bang for your buck. And then I'll even start doing it when I'm doing safe ankle movements like eversion, or even active dorsiflexion to neutral, and plantar flexion pumping type of motions, I'll use the blood flow restriction just to try to get a little, it doesn't hurt to do it, right? So why not try to get as much out of the exercise as you can? And really what blood flow restriction therapy and training allows you to do is really kind of create that hypertrophic environment at sub maximal loads, like 20 to 30% of that 1 rep max. You can start, gaining some of those, or creating that environment and that metabolic stress and that tension through tissue that normally wouldn't benefit from or couldn't benefit from loading, because it's not safe to put a whole lot of load through that tissue to get to the point where you're really creating that type of environment, that lactic acid, et cetera. So, long term, if you can load tissue, load it. But early on, I think blood flow restriction training was made for Achilles tendon repair rehabilitation, because it really accelerates your ability to kind of get a jump start on starting that strengthening process. And again, I believe really wholeheartedly that it's the strength deficits that hold these athletes back long term, and it's not the actual healing of the tissue that kind of holds them back.
Yeah, it's pretty perfect for those conditions where someone's load compromised, but you do
Correct.
need to load them up and create some physiological change. For anyone who wants more information on blood flow restriction, in an earlier episode of the podcast, I spoke to Dr. Nicholas Rolnick, who's a blood flow restriction researcher. So he goes deep into some of the things that Scott mentioned, like the parameters, the systemic effects, and et cetera, et cetera. Okay, so you made a point there how it's difficult in the case of an Achilles rupture to work on the strength because there's that protection phase. And you also said how gaining mobility is a really important thing so that we could have this good sort of framework, or this good motion to build strength upon. But that's another issue when it comes to Achilles rupture rehab, right? Like, we're not allowed to go into too much dorsiflexion too quickly. So can you touch on sort of how you build strength while making sure that you're not stretching out the tissue too quickly?
Yeah, that's great. That's a great question. And so, when I talk about the 3 keys to Achilles tendon rupture rehabilitation or repair rehabilitation, number 1 is wound closure. Number 2 is don't stretch the tissue out. Number 3 is get strength as quick as you can without stretching the tissue out. Because again, if you get that tissue creep, or if that tissue stretches out, especially in an athlete, you're really going to, you're really going to limit their performance. They're going to lose their ability to be explosive. And once that tissue loses that explosive quality, that stiffness, there's no getting it back. It's like the toothpaste has left the tube, and you can't put the toothpaste back in the tube. It's like an old rubber band, right? The rubber band that's stretched out, and it's just, you pull it back too hard and it just doesn't shoot nearly as far as it used to, right? So that's the problem with stretching these out too much. So I tend to stay away from any type of passive stretching beyond dorsiflexion till about 5 months. And that's just me. That's just my handle on it. That doesn't mean that I limit dorsiflexion to neutral in all situations with regards to their return to function. Like, there's plenty of exercises that we do that gets them beyond that neutral phase, let's say. Like, for example, they start running in most cases by about, 4 months, 16 weeks, give or take. So that's a month earlier than I would really get my hands on them and really start loading them. But really, I'm not really cranking on dorsiflexion until I see it really being a deficit. And with a lot of the things that we're doing, squatting and lunging, you getting some of that back, but I'm just not doing any prolonged, long duration, low load stretching to that tendon. That's just me. And I will do some talocrural mobilizations and those type of things to make sure the joint itself continues to move okay. But I'm definitely not going to be, like I said, getting them on a slant board, trying to stretch them out.
Right.
Or even putting my hands on them and forcefully dorsiflexing them.
Mm-hmm. And when you're saying that you wouldn't really do those sorts of things until you're noticing a deficit, do you mean, if they start to run and they find that their mobility is really, really restricting them, then maybe you'll do something about it?
Correct. Okay. Yeah, correct. And again, you get a good idea as to when people are moving. Do they have good? There are 3 rockers we'll call it in the gait mechanics cycle. There's the heel rocker, the ankle rocker, and the forefoot rocker. If you're noticing a decrease in the ankle and heel rocker, and they're kind of vaulting and they're not kind of getting through into dorsiflexion, then that's something that you definitely want to address. And you can watch them squatting. If they're squatting and they're not getting over it, and they're getting away from it, they're not getting the depth. And, step ups are a challenge for them, or stepping down actually is a challenge for them, especially on the trail leg. That's a problem. So a lot of that you'll kind of see. And I think they work through it in some of those functional activities.
Right.
But again, I'd much rather them get it back doing some of those safe functional activities as opposed to me, I think I can do more damage to them by me cranking on it and doing some of that prolonged load stretching than just some basic functional activities. Now, again, the amount of weight you load on somebody is going to play a part in that too. And you just got to be mindful. But, there was a good study, I think it was by Baxter. And I think Karin was involved in this study as well, where they kind of characterized into like four tiers of different strengthening exercises and, what's safe. Not necessarily what's safe, but like what puts the least amount of load through the Achilles tendon in an exercise fashion and what puts the greatest load. And you can kind of see where certain movements kind of are in the spectrum versus something like walking and running, like where they are in the spectrum. For example, like walking is a tier 2 activity and running is a tier 3 activity. The highest loaded exercise I believe that they had in the tier 4 was forward hopping on one leg. That put the most, we'll call it loading index, which was a combination of loading peak and loading impulse and loading rate. They kind of characterize all three of those factors into one, loading index, and forward hopping on one leg was the highest. And the lowest they had, so the easiest or most least invasive, we'll call it, to the Achilles tendon was a bilateral seated heel raise without any resistance, right? So I think that's something you can start pretty early on in the rehab process. You probably can start that, probably in the 4-week mark. Start doing some seated, no resistant, just kind of going up and down on their toes with both feet. So good study.
Yeah,
one of my benchmarks that I like to refer to.
I think it's a great study, and it just goes. It sort of provides a little bit of detail as to why it's okay to do those seated heel raises early on. But again, you're not walking at that point out of the boot because that would be a tier 2 movement.
Correct.
There. It'd have a higher loading profile.
Correct.
Yeah. So I used to maybe around the 12-week mark or so start to allow people to start stretching into dorsiflexion a little bit because that's what most of the protocols had said, and I would typically follow those. So I do think it's an interesting take to sort of just get the dorsiflexion range of motion back through the more functional exercises like a squat, like a lunge, or these step downs, as opposed to not stretching it so much. I used to have this concern though, Scott, that if we didn't get it back quick enough, then we may be limited in the long run. And when I say quick enough, I don't mean that, we're stretching week 1,
right?
But I didn't want to wait too long. Do you find that you're typically able to restore people's full mobility, even though you start making more of an effort towards getting their range of motion back around that, month 4, month 5 mark?
Yeah, I don't feel like the dorsiflexion restriction is something that lingers once you start, having to kind of load it and put some, and safe to load it through those type of mechanisms. It's not like the knee where if you don't get the motion back, it's going to be very hard to get back. I think because, the ankle and into dorsiflexion is something that our body weight kind of, puts load through every step we take. Right. Mm-hmm. So I think, again, my opinion, that, our daily activities and our strengthening activities that we're doing are adequate enough to help us along. And then again, if in fact at the 5 or 6 month mark we find that we're lagging, I think we have enough time to still work on getting some of that back and being more aggressive if needed. But I haven't found really the need to get too aggressive with doing that, based on the fact that, again, it's not saying I'm not moving them into dorsiflexion. I am, but I'm doing it in the premise of these exercises and a graded exposure, as opposed to any type of prolonged duration, low load stretching, and any forceful kind of me grabbing them and cranking on them and trying to get as much out of it as I possibly can. I just, again, risk reward for me is just not there. And I haven't found any long-term negative detriment to waiting that extra month and a half to kind of do that.
Right. You could have this sustained stretch at the bottom of, let's say, a calf raise on a step, right? Calf raises are the staple, probably the most important exercise in all the different variations that there are for this type of rehab, right? So can you walk us through sort of like a typical calf raise progression? Because I think a lot of people will understand, like a single leg calf raise is harder than a two leg calf raise, but we
Mm-hmm.
also really need to consider the dorsiflexion range of motion in this equation as well, right?
Yep.
So how do you
So,
typically progress it?
so I love the shuttle. The shuttle is one of my favorite exercise machines for the Achilles repairs, because you can kind of it's less than body weight oftentimes, right? And it's a really good way if you needed to get into that, extreme dorsiflexion range at a certain time and take them through that, you can. But at the same time, you can also get them a little bit higher up on the pad and really protect them and keep them neutral, right? So I think
Nice.
it's a great transition. The question is, when do you transition into taking them beyond the neutral plane? And again, I think you got to look at some of the other exercises that they're doing, and based on the stresses that those exercises are enduring and the qualities of movement that they're requiring, will let you kind of know where you stand with that. So usually around I'd say I keep them pretty much into neutral dorsiflexion until about probably 3.5 months post-op.
Okay.
And then I might start taking them a little bit beyond that, depending. But you can also do things like, eccentric loading to neutral dorsiflexion. I do a lot of work at terminal plantar flexion, because I think that's a limiting factor too. People not getting their terminal plantar flexion strength back. So I'll do a lot of iso holds at terminal plantar flexion. There's a lot of different ways to skin this. I use BFR all the time when I'm doing my calf raises as well, because I can keep the weight light, but I can still challenge them. And this way I'm not worried about putting a whole lot of load through that tendon into the negative phase. So maybe early on, if I am going to take them beyond neutral, maybe I'll lighten the load quite a bit and then just put the BFR cuff on them and allow them to take themselves down through that range, but not have that heavy load kind of pushing them down into that position.
Right.
So that's something that I'd also consider doing. So there's a lot of different ways in which you can kind of play with it, and just keep in mind what the goals are and what you're trying to protect. So that's what makes it fun, right? There's not one size fits all, and not everyone has BFR. Not everybody has a shuttle. There's a lot of different ways in which you can do it. A lot of times I'll use, single leg calf raising is always a staple for, return to sport and how well they're doing. And it's a challenge, right? So I'll oftentimes have people using like bands where they can actually, grab onto a really thick resistive bands to get some assistance, but it's not the same type of assistance as grabbing like a counter that's not moving at all. With the bands, they move a little bit, so you are kind of using you're not able to compensate nearly as much with your upper extremity with the band versus a solid surface like a counter or a rail or whatever it may be, a table.
Right.
So
and this would be a band that's strapped up to something above.
High up in the air, correct. Like we have, whether it's a squat rack you tie it to or a pull-up bar, whatever it may be, you can pull it up real high, have them, and then you can vary the amount of thickness of the band, right, to make it more challenging. Go to a thinner band as they get stronger. So, and again, the beauty of that is you can start them off in a really flat position where they're not going beyond neutral. And then if you wanted to, you can always get them on a step and do that negative kind of focus there too. So lots of different ways in which you can progress and challenge, but I have found that getting terminal plantar flexion strength back is a challenge and super important.
Yeah, we're hinting at a few outcome measures here, right? We've talked about dorsiflexion range of motion. We've talked about that terminal plantar flexion sort of height, I guess we could call it.
Sure.
What are some of the most important sort of outcome measures that you consider when it's time to consider return to play or return to sport?
Sure. There's a lot of different ways. So I think Rob Penarella actually mentioned this in a LinkedIn post not too long ago that I read. It's pretty interesting where you do some toe walking for, I believe it was 50. It was 10 yards. It was 10 yards, and I think you did 5 of them. And you walked. So you did your toe walk for 10 yards, and then you walked back to the start, and you did that 5 times. And each time you do it, you want to make sure that the heel on the involved side and the heel on the uninvolved side doesn't drop in terms of the height in which you're lifting it or raising it or keeping it elevated off the ground. So that's one way in which you can try to determine, whether somebody has adequate strength in their calf musculature and tendon, etc. Then you can do more things like, single leg hop tests, where you're looking for, whether it's 90% symmetry between the two sides. You can do that. You can do repeated hop tests. How many in a row can you do, or how high can you jump test? How high can you jump? You can do force plate testing, where you're looking at counter movement jumps, right side versus left side, symmetry indexes. You can do, on force plates, reactive strength indexes. You can do, on force plates, you can do things like ISO calf strength, looking at peak force, etc. And again, all of these are going to vary in terms of what the normative data shows. Whether it's in a standing position, you might see, I think some of the VAL data shows anywhere between, depending on the sport and the type of, whether it's male or female, anywhere from like 3 to 4 times body weight in those type of settings. Whereas I also use something that's called, basically a dynamometer, and I do it in a seated position, 90-90 position, where you're kind of really looking at soleus. And checking peak force there. And I think there it's somewhere between 1.5 or 1.7% of body weight, something like that. So all of those metrics are all useful depending on what you have. But, you got to test something, right? You got to test something. And, people, sometimes you can do isokinetic testing on the Biodex. It's a pain in the neck to set up sometimes, but you can do, plantar flexion strength on that. So a whole host of different ways in which you can do it.
Okay. And I think something that you've really brought to my attention when it comes to Achilles ruptures is that the testing that you choose, it should definitely correspond with what the individual wants to get back to doing. You need to consider the demands of their sport. So in your case study for Physio Network, it was a gymnast, right? And they may have different demands than a wide receiver, who may have even different demands than someone within the same sport, right? Like a quarterback.
1,000%. So, I'm actually giving a talk in a couple of weeks at the Combine. It's talking about Achilles tendon repairs. Does position matter? And my answer is yes and no, right? So that it's more than just position, but position does matter. But at the end of the day, you got to get you got to get strength back, right? So
right.
There's got to be a bare minimum of where you got to get to. But there are many studies out there that show, return to sport rate in different positions in football varies. Tight ends versus quarterbacks versus wide receivers versus linebackers, defenders. It's all going to vary depending on what the demands are. Then we talked about the needs of that particular individual. Are they somebody that's ending their career, towards the end of their career? Are they a quarterback? For example, we talked a lot about Aaron Rodgers off air, whether or not, it wasn't his push leg. He's a 40-year-old quarterback that doesn't rely on speed anymore. He doesn't have many years left in his career. So was he willing to maybe try to accelerate his rehab more so than normal just because he needed to get back quicker, because he did, time is of the essence for him. So, if he's willing to take that risk of maybe, losing some of that explosiveness because he stretched his Achilles tendon potentially earlier than he should have, and more than he should have, maybe he's willing to take that risk, right? So, not everyone is going to follow the same protocol. Not everyone is always going to, be as aggressive as somebody else. And, what do you have to lose in the whole thing, right? So I think it does matter. I think sport matters. We talked about, in a case study, let's say, where a gymnast may get back to doing, and that's pretty neat, where like a sport like gymnastics, the different apparatus have different demands, right? So, for example, somebody that tore their Achilles may get back to the bars as their first apparatus back, but if they had a shoulder injury, it would probably be the last thing they come back to, right? So, I think for me, with a gymnast and landing, let's say, landing, if we look on the tiers and how much load that it puts through the Achilles, it's pretty low. A bilateral landing from, drop land onto 2 feet is pretty low relative to some of the other things, right? So we may be able to, and we are able to get our gymnasts and those type of athletes back quicker to that sport, whereas that exercise, or however you want to classify that event's probably the best way to classify it, versus say the floor exercise or the vault, right? So those are a lot more demanding. Those events are where most Achilles ruptures occur. So the stresses are higher. So all of that plays into the equation, what the goals are, what the safety is, how strong they are. All that kind of plays into the time frame as to when and who and how they all come back.
Right. And what you measure. But as you mentioned, everyone sort of has to meet some of the standards, right? Like you do have to get your range of motion back. You should probably have a calf that's as strong or close to the
I don't
strength
think
as the
as
other one.
strong. You're not going to have it as strong at a certain period of time, but it needs to be strong enough, right?
Okay.
Whatever that means, strong enough to deal with the demands of what you're doing, right? So,
Yeah. Do you ever see that strength fully return?
you do, but it takes time. It's I've seen it take obviously 2 years in some cases to return back to where it needs to be in terms of full symmetry. It doesn't mean that they can't participate in sports until they're 100%. No, that's not the case. But there needs to be some level of strength that allows them to do something. And oftentimes, for me, the baseline is they've got to be able to do some toe walking for any length of distance without losing that heel height. That's like bare minimum for me to kind of get people back doing some higher level things.
Cool. Got it. So you briefly mentioned it. I think when people hear or think about Achilles ruptures, one of the first things they think about these days is Aaron Rodgers and his Achilles rupture. It was one of the biggest stories I think that I could think of when it comes to Achilles ruptures. And some of the more, I guess, controversial or noteworthy subjects there was the nature of the surgery. There's talks of this, like revolutionary surgery at the time, this groundbreaking new protocol that he was going to do, and also how quickly he was going to get back to his sport. It seemed like that was a very, very lofty goal. So can you just share your thoughts on that surgery and also just that accelerated recovery and whether or not that's possible for someone like Aaron Rodgers?
Sure. So we'll talk it in the preference of Aaron Rodgers with air quotes, but cause I haven't read his op report and I don't know exactly everything he did in rehab. But let's say what we know commonly is that he did have what we call a speed bridge or an internal bracing type of procedure to go along with his repair. And that basically, what that does is it basically takes almost like a longitudinal suture in line with the fibers of the Achilles tendon and attaches it, anchors it into the actual bone of the calcaneus. Okay, so it creates a nice, strong, bony repair to go along with some of the suturing that may occur in conjunction with that. So it's a pretty strong repair. And then we start talking about the accelerated rehab, where you saw him, his goal was to get back in like 4.5 months back to playing football, NFL level football as a quarterback, right? And we talked a little bit about the requirements of maybe his risk reward. He's not an athletic quarterback at this time in his career. He needs to be able to escape the pocket and protect himself, but he's not Michael Vick. He's not one of these guys that, that makes a living with his legs anymore, so it's not his push off leg. So we'll be generous and say at the time of the injury, let's say 5 years left in his career. Let's say we get him to 45, right? Versus somebody that's, 20 or 21 or 22. And actually, to be honest with you, the return to sport rates, I think the career length after an Achilles tendon repair on average in the NFL is like 2 years.
Wow.
After the repair. So it's pretty short. The life expectancy after it is not great. So, if he can get back quicker and kind of do some of those things, and still run the risk of maybe losing some of his explosiveness, he may have been willing to do that. You will say that he was out of the boot a lot earlier than most. I'm sure he had a heel lift in. I'm sure he did. For how long, I don't know. But some of the things he was doing, like if you look, BFR was a big part of his protocol, and I don't know if he had anything else injected, if he had PRP injected, stem cells. I have no idea about some of the other stuff that may or may not have taken place in that procedure. And I didn't sit next to him at the table watching his rehab every session. But, those are some of the things that you saw him really get involved in. He was more aggressive than I'd say I'd potentially be comfortable with in most cases, not all cases, in most cases. But again, that's where that conversation between, and if you watch the, I think it was the Enigma was the special they did, the documentary on him, if I'm not mistaken. And they had one of the scenes where he was in the room with with Doc and the athletic trainer himself, and I'm not sure who else was in the room, and they were talking about Aaron's like, this is when I want to come back, and the doc is like, well, I think that'll be okay, and we really don't want to stretch it out too much, So it was nice hearing those kind of conversations take place, and that's really what it's about. It's about making an educated decision based on science and expectations and how things are progressing. Maybe he had some good diagnostic imaging done at certain phases of the rehab that showed good healing, and they were satisfied with that. But yeah, it pushes the envelope. And what the scary part about it is, if he did come back, which he didn't, he wanted to, but at the end of the day, he didn't. Does that really push the expectation for the common folk up and make it so that everyone is comparing themselves to when he would have returned? Yeah. And I don't think that's fair, because again, every situation is very different, and I think we need to be cautious, but aggressively cautious, with keeping in mind healing times and healing frames, and how you make this gradual progression back to sport.
I remember speaking with a few Achilles ruptures patients at the time that this was such a big story. And they could not imagine, playing a sport at that time frame around that like 4 or 5 month mark. But I think an important distinction there, and an area that would confuse people, is that they may think that if he did return at that time, he may have been, like fully recovered in terms of functional metrics and performance metrics. But that may not have been the point.
That would not have been the case. Right. I'm almost 100% certain to say that would not have been the case. Even when he came back, to start the next year, he still did not move well early on in the season. It took a little bit of time. Me being, if you look in my room here, you can kind of see the Jets blanket over there. So I'm somebody that watched every single snap that Aaron Rodgers has taken since the Achilles injury. And I, again, who am I sitting on my couch watching it? But, he felt more confident as the season went on. And then other injuries crept in, and he slowed down a little bit, and there were some other things nagging him. And it's hard to say, again, from an outsider's perspective, what else was going on. But he didn't move like himself pre-surgery. There's no question about that.
Yeah. And I guess this sort of is a good segue into my final question, which is in terms of recovery and just sort of expectations. Do people ever make a full recovery from Achilles ruptures? If so, how common is that?
Yeah, I think they do. I have plenty of athletes that are back doing their sport, competing at a high level. With Florida athletics and such. I see, youngsters, 18 to 22 years old, let's say, rehabilitating these type of injuries and getting back and competing. And I have several of my athletes now that have done that and are doing very, very well. So it's definitely going to be skewed by sport. If you look at the data, again, sports such as basketball are challenging because, again, it's such an explosive, jump heavy type of sport.
Yeah.
If you look at track and field athletes such as jumpers, like triple jumpers and long jumpers, high jumpers, another one that's a little bit of a challenge, let's say, to really get back to, and those tendons are under load all the time. So that's up there. And then if you start looking at like baseball players, right? Baseball players, especially if they're playing like first base, or, some other position, DH, right? Here's a great example, DH. They can get back and do very, very well as a DH, with an Achilles tendon repair, right? Because their demands of what they're asked to do are different than, say, what a gymnast needs to do or what a basketball player needs to do. And if you look at the sport of basketball, most of the athletes on the court are doing similar things. They're all jumping, running, hopping. Right. Whereas, again, in football, what the quarterback has to do is very different than what the wide receiver has to do, which is very different than what the center has to do. Offensive linemen need to be powerful. They don't need to necessarily have reactive strength nearly as much as a wide receiver, who also needs speed, right? Straight plane speed, lateral speed, so that is another factor. So again, you can't have speed without strength, like we talked about earlier. So you got to build that base. But again, you got to take it to the next level and retrain those tissues to be more reactive and more explosive and such. So, yeah, there's a wide variety of return to sport rates, and how good the pair was, how good the diet nutrition, I think, is oftentimes overlooked. Genetics is another one. I don't think every athlete, I don't think every athlete regains their strength at the same rate. I have plenty of examples where I'm rehabbing two athletes very similar sport with the same injury. One, for whatever reason, does a lot better than the other one, right? Or regains strength a lot quicker than the other one. So it's not necessarily the rehab. It's oftentimes the other factors: how well they're sleeping, how much stress they have, what their nutrition looks like, what are their genetics. All of that kind of is pieces of the puzzle that has to come together for that given particular person.
Makes a lot of sense. And the fact that these athletes can get back to their sport and oftentimes perform at a level similar to what they used to, I use that to sort of discuss with patients who maybe don't have lofty athletic goals, that they could get back to a life that feels pretty normal. Because again, this injury is unlike most that people experience. And I think when they first get it, there comes a lot of dread and concern with it. As they're in this boot and they can't walk and they maybe got the surgery, they could be very worried. So I like to tell people that, listen, like, there's athletes that get back to their sport. Like, you could likely get back to the life that you want. It just will likely take some work.
Yep, 100%. 100. You look at the NFL field on any given Sunday, and there are plenty of people out there that have had Achilles tendon repairs. Again, various positions, various ages, various different surgical techniques. All of that plays into it. Even if you look at this past year, you look at Kirk Cousins, his recovery versus Aaron Rodgers, both roughly around the same age, give or take. One was a lead leg, one was a push leg, one was a land leg, so a little bit different there. And they both had their limitations, right? They each of them struggled in their own way this year. Whether or not it was due to the Achilles, hard to say, but they each had their struggles.
Yeah. All right, Scott, any departing words, any things that you want to touch on that maybe we didn't hammer home enough? Or do you feel like that was a pretty good summary of Achilles ruptures?
Yeah, I think it was a good summary. I think that the most important take-home message is really be mindful of wound healing, really be mindful of allowing the tissue to not inappropriately stretch, and then get strength back as safely and as quickly as you possibly can. Perfect. Those are the real important things to take home from this.
Okay, I love it. Scott, thank you again for coming on. I really appreciate it. I think this provides a really nice sort of framework for people dealing with this injury, and physios as well that are helping manage this injury, because I feel like not a lot of people have a ton of experience with it unless they're working in sports medicine. So thanks again for coming on and just sort of giving everyone a little bit of a masterclass on Achilles ruptures.
Well, I appreciate the invite, and it's always fun talking about this stuff. So I appreciate you very much.
My pleasure.